So welcome to the second of our 6 webinar series on cirrhosis care, practical tips you can use in your practice today, brought to you by the Office of Lifelong Learning. My name is Anita Tandon. I'm an associate professor of medicine and co-director of the Cirrhosis Care Clinic and transplant hepatologist at the U of A in Edmonton. And I'm also medical director for the Office of Lifelong Learning and the Physician Learning Program. And the Office of Lifelong Learning is committed to providing the latest information, advice, and resources related to cirrhosis care for physicians and other healthcare providers. Just before we begin, I would like to acknowledge that we are on the traditional territories across Canada of the many First Nations, Métis, and Inuit, whose footsteps have marked these lands for centuries. We are very pleased that Dr. Guadalupe Garcia-Tsao will be sharing with us her presentation entitled Don't See Cirrhosis Often, the Top 10 Things You Need to Know. Lupe is a professor of medicine at Yale University. And she is the chief of the section of digestive diseases at the VA Connecticut healthcare system and director of the clinical core of the Yale Liver Center. She is a leading expert on cirrhosis, portal hypertension, and related complications. Her research has mainly been patient-oriented, and she's authored over 150 PubMed publications, which have been cited over 35,000 times with an H-index of 85. She's an absolute phenomenon. She served as the president of the ASLD in 2012. She's associate editor for the New England Journal of Medicine. She's had numerous rewards, including the International Recognition Award and the Distinguished Clinical Educator and Mentor Award. And she's been my favorite mentor, my first and my favorite mentor in my hepatology fellowship. So I am super thrilled to have you here today, Lupe. Thank you so much.
Thank you so much, Punita, for that super amazing introduction. I'm not as amazing as she made me sound, but anyhow, that's because she likes me. So let's start. I'm going to start by dedicating this lecture to my mentor, without whom I would not be here, who just passed away this weekend, Dr. Grossman. And let's start by saying that cirrhosis has 2 main stages, compensated and decompensated, that should be considered 2 different disease states, really. The decompensated patient is defined by clinically overt complications, variceal hemorrhage, ascites, or overt encephalopathy. And they're entirely different because the compensated patient, while he or she remains compensated, is going to have a median survival that exceeds 12 years. Whereas once the patient decompensates, the median survival decreases to about 2 years. So half the patients are going to be dead in 2 years. Now, let's talk. I'm going to talk then, because I understand that Dr. Abrales talked to you last week about compensation. So my talk today is about the 10 things to do with decompensated cirrhosis. So variceal hemorrhage is an episodic, but it's a deadly complication of cirrhosis. So, but we have done a great job at making survival better, or at least until the 2000s, we had greatly improved the survival. And in this particular study, the predictors of the improved survival over the years was the use of prophylactic antibiotics and the use of ligation compared with sclerotherapy. So let's talk about prophylactic antibiotics, which is one of the things that you should know. Prophylactic antibiotics, there's a meta-analysis of 5 trials of randomized controlled trials comparing antibiotics versus no antibiotics in patients with cirrhosis and any GI hemorrhage. And you can see here how infection rate is significantly lower, but importantly, mortality is significantly lower in patients on antibiotics. And part of this improvement in mortality is because these patients actually rebleed less, and there's also evidence about this, and it's probably because you're decreasing more vasodilation, more flow into the system, and that may actually curtail bleeding. Now, in all these studies here, what the antibiotic that was used was mostly non-absorbable antibiotics, norfloxacin, because the theory was that bacteria that were coming from the gut was the one that was causing the infections. But then, it was hard, first of all, we don't even have norfloxacin in the US anymore. and you have to put it when the patient is vomiting blood, right? So then this trial came about that compared IV ceftriaxone versus oral norfloxacin. And they found that actually IV ceftriaxone was better than norfloxacin in preventing bacterial infections, and specifically in preventing SBP or spontaneous bacteremia. Having said that, many of the patients on oral norfloxacin had quinolone-resistant organisms, which is something that's also very prevalent. So because of the ease of this and everything, this is the antibiotic that we recommend. I must also mention that these patients all had advanced cirrhosis, so they were really decompensated. Dr. Tandon herself did this study that looked again at the beneficial effects of antibiotics, and it would seem that it mostly benefits patients that are child B and C. So for death, clearly child C patients are the ones that benefit the most from antibiotics. Child A, so-so. Now, what is the other measure after the Carbonell study that could improve survival is the use of a restrictive transfusion strategy. And again, this was a study in the New England Journal of Medicine of any GI hemorrhage. And you can see here that they compared a restricted transfusion strategy is that you start transfusing only if the hemoglobin goes down to 7, and you target the transfusion to around 8 grams per deciliter, whereas the liberal strategy was you start transfusing if it goes down to 9, and you keep it around 10. You can see here, there's a magnification of this curve down here, and you can see that there was a significantly lower mortality probability of dying in patients with restrictive transfusion strategy. Now, a third of the patients had cirrhosis. So I'll show you the data on these patients. So in cirrhosis in general, when we looked at mortality, although it was lower with the restrictive strategy, this did not quite achieve statistical significance. And it was only when you stratify by child class A or B. You can see here that the AB had significantly lower death rate, and this was significant. Whereas child QC, because they're already very sick patients, there was no benefit, but there was not a higher mortality. When they looked at rebleeding, again, patients with cirrhosis, this time it was significantly lower. Rebleeding rate was significantly lower in those that got a restrictive transfusion strategy. And again, when they stratified by child A, B versus C, the benefit was significant in the more compensated patients. But look at this, 28% versus 15% is pretty good. So I would still say that child C derives some benefit of the restrictive transfusion strategy. What is very interesting is that in experimental, and why is this? It's because nature is very wise, and when the patient bleeds out, the blood pressure goes down, the flow through the varices decreases, and patients stop bleeding. In experimental animals, actually in Dr. Grossman's lab, when they would take out blood and return the whole amount of blood that was taken out, the portal pressure would shoot up to higher than baseline. Whereas if they only transfuse part of it in, that would be the bleeding and the pressure would be lower. And they found this in this study. They measured the hepatic venous pressure gradient, a measure of portal pressure in those with restrictive strategy, and the HVG did not change. Whereas in those that got the liberal strategy, the HVG went up, the portal pressure went up. So it makes sense. Do not tank these patients up too much. So Baveno 6 recommended that packed red blood cell transfusion should be done conservatively at a target hemoglobin level between 7 and 8. Other things is that in terms of coagulopathy and thrombocytopenia, there's no recommendation that can be made. What we do know for a fact of life is that the INR is not a reliable indicator of coagulation, and you should not go crazy about trying to correct that. So this is our initial management. This is just general management. Cautious red blood cell transfusion, short-term antibiotic prophylaxis, and I must emphasize this is short-term. You're not going to do it forever, and you start a safe vasoactive drug. You do an endoscopy within 12 hours, and you confirm that this is variceal hemorrhage, and you do endoscopic variceal ligation. One point that I want to make that is, even though at the beginning you may want to give a PPI just in case this is a peptic ulcer, once you've confirmed that this is variceal hemorrhage and not an ulcer bleeding, then you can stop the PPI. Now, what about endoscopy? How do you make the diagnosis of variceal hemorrhage? You do it well, obviously, if you see a varix that's spurting blood, or if you see blood around a varix or a clot around a varix, but you could also just see a white nipple sign, which is a clot there that just stopped the bleeding. But most importantly is that if you find varices without any of these signs, and you don't find anything else that could explain the bleeding, this patient has bled from varices. And this is something that is often not recognized. Now, talking about variceal hemorrhage, I'm a little bit obsessed about portal vein thrombosis and people looking for it unnecessarily. So if you have a clot right there, obviously the pressure, distal to the clot is going to increase, and therefore these varices, the pressure may increase, and there is the risk that the patients may bleed from variceal hemorrhage with a portal vein thrombosis. But if this is the case, then you do the standard management as I showed you, and you consider tips earlier rather than later. Now, if this clot extends into the superior mesenteric vein and occludes it, this is a major problem because this will lead to intestinal ischemia and necrosis, and the patient will present with abdominal pain. And this will require immediate anticoagulation and surgical consult. So this is an emergency. PVT should always be investigated, and the patient with cirrhosis presenting with GI hemorrhage or presenting with abdominal pain, and the latter is actually much more important than the GI hemorrhage part. Now, on the other hand, think about it. Even though this clot may be occluding the portal vein, you will always have blood flow to the liver from the hepatic artery. So, it isn't like by causing portal vein obstruction, you're going to get ischemia in the liver or you're going to get any problem like that. Because in fact, in cirrhosis, the flow from the hepatic artery is much higher than in the normal population. So because portal vein thrombosis will not cause a decreased blood flow to the liver, it will not lead to liver enzyme abnormalities, jaundice, worsening ascites, or encephalopathy. So therefore, there is no need to investigate portal vein thrombosis in patients with cirrhosis presenting with these complications. And I see that all the patients that come in with whatever, they do a Doppler or they do cross-sectional imaging. This is not necessary, all right? Now, moving on to ascites. What are the important things that we want to look at? This is the pathophysiology. You have sinusoidal hypertension, fluid leaks into the belly, you get ascites. But this would be a finite process if it weren't, because the systemic circulation continues to be replenished. So these patients, the sicker they get, the more systemic inflammation they will get. This leads to vasodilation, decrease in mean arterial pressure, activation of neurohumoral systems that lead to sodium retention. This replenishes the volume, and therefore this perpetuates ascites formation, right? Now, if the patient gets sicker, they get more inflamed, more vasodilated, decreased pressure, more activated of neurohumoral systems. Now they're retaining sodium very avidly. They will not respond to diuretics, and they now have refractory ascites. If, in addition, there's an excess of antidiuretic hormone, which is one of these neurohumoral systems, now they will be retaining water in excess of sodium, they develop hyponatremia. And finally, when maximally activated, you'll get renal vasoconstriction and hepatorenal syndrome. Now, what do we do now for ascites? We act way downstream of the pathogenic cascade. We restrict sodium with diuretics. These have not changed the survival of the patients at all. It's symptomatic therapy. With refractory ascites or with tense ascites, we do an LVP. We take out the fluid. This is furthest downstream of the pathogenic cascade. So we're really doing nothing upstream so far with our standard therapy for diuretics. In LVP, actually, LVP makes vasodilation worse, so we give albumin to prevent complications from LVP from occurring. So ascites, what I want to emphasize is that a patient with cirrhosis does not need to be hospitalized for treatment of uncomplicated ascites. This is not like pulmonary edema that requires IV diuretics and immediate diuresis. Ascites is not an emergency. You can start the diuretics once other complications, GI bleed, infection, AKI, encephalopathy are absent or have resolved. If the patient is very uncomfortable, you can always do an LVP, always associated with albumin. In a non-elective admission, the first thing you have to do is stop the diuretics. You hold them because diuretics, like I said, are not saving their lives. If the patient gets uncomfortable, you can do an LVP, and they may actually causing AKR or some deleterious effect. In a patient with ascites, the main job and the main key point is that you have to make sure that you don't miss the diagnosis of SBP because this is a lethal complication. So how do bacterial infections, what happens with the bacterial infection? It can affect the patient that's decompensated or a patient that has this further decompensation, which is when the patient develops complications of the complications. And what happens? They now get they get organ failure. They have renal failure, they have liver failure, the coagulopathy system is wrong, they get encephalopathy. And then this is defined as multi-organ failure, and the patient is going to die in the mortality is high in 30 days. But these infections can also affect the totally compensated patient and lead to multi-organ failure and death. So bacterial infections are incredibly important to detect timely and to treat them in a timely way. So in cirrhosis, what are the most common infections? The most common, and this is 33% of the infections, are the so-called spontaneous infections. And they're called spontaneous because there's no abscess, there's no perforation, there's nothing that would indicate why the patient is infected. And they're mainly SBP, spontaneous bacterial peritonitis, bacteremia, which is actually the initial pathogenic event where bacteria are escaping perhaps from the gut into the systemic circulation, and then they see the ascites, or they see the hepatic hydrothorax, which is spontaneous bacterial pyema. And I just forgot one thing that you should know, which is never put a chest tube in. It's not in my final conclusion, but I just thought about it right now. This is not empyema like you would have with a pneumonia. This is infection of the fluid of hepatic hydrothorax. Therefore, it does not require a chest tube. This data from this slide and the reference from how this appeared is the same as a more recent paper that showed that 38% of the infections are spontaneous in a recent worldwide study of infections. So, are we good at diagnosing SBP clinically? No, we're not. So in this study, this is a German study, 6 out of 17 patients in whom the clinician said, oh yeah, this patient definitely does not have SBP, 35% did have SBP. So as clinicians, we're not very good at diagnosing SBP. So the patient may present with abdominal pain, tenderness, ileus, but it's often asymptomatic, and the patient may present only with encephalopathy or acute kidney injury. So your awareness and so if anything wrong is happening to the patient and the patient has ascites, you tap the belly, because the result, the diagnosis of SBP is made with a polymorphic nuclear count of more than 250 per cc. That if it's a hepatic hydrothorax, you make the diagnosis of spontaneous bacterial empyema. So what do you do? So if the patient comes in with a non-elective admission, the patient is there for something. So you stop the diuretics, you do a diagnostic paracentesia. If it's more than 250, you start an antibiotic. We often have patients that have spent the whole day in the ED, come up to the ward, and they still haven't had a tap. And I remember distinctly a patient of mine where this happened. He was not tapped in the ED, came to us, and by the time he came to us, he was in septic shock and died from Klebsiella. He had SBP and bacteremia. So the more you delay in doing that paracentesis, it has been shown that the mortality increase. So the paracentesis has to be done ASAP. The other patients that present with SIRS, I mean, they're hypotensive, they have a fever. and or acute kidney injury or jaundice or encephalopathy, there's already signs of this multi-organ failure going on. So they need to be pan-cultured. And once they're pan-cultured, and this includes the diagnostic paracentesis, you start an antibiotic. In this study, in patients with cirrhosis and septic shock, there was a 10% increase in mortality with each hour of delay in initiating antibiotics. And if you use the inappropriate initial antimicrobial therapy, that increased the odds of dying by 10 times. There's going to be an ASLD guidance coming up very soon in the next month or so, where we actually specify how to do this, or what antibiotics to start. Now, if the patient comes in hypotensive, which is part of the SIR syndrome, with a blood pressure of less than 90 or a MAP less than 65, and the patients are non-selective beta blockers, these need to be held. Now, acute kidney injury is a complication that occurs in the patient that's decompensated. And it happens in 20 to 50% of hospitalized patients with cirrhosis, and we're going to see it probably more and more in the setting of in acute on chronic on a chronic CKD in patients with NASH. And so it's very important that in patients with AKI, you have to do general measures, and it depends on the pathophysiology. What happens, I showed you it previously, this is inflammation, and an infection can definitely drive acute kidney injury that leads to vasodilatation, decrease in effective arterial blood volume, activation of neurofilament systems, this is to renal vasoconstriction, and this leads to a pre-renal type of kidney injury that could be HRS, but could actually just be a part of having a precipitant. So if there's vasodilation, the driving force, which then could be HRS, you have to always investigate infection, like I talked to you about. You have to discontinue non-selective beta blockers and other vasodilators. You avoid large volume paracentesis because, as I told you, these can lead to vasodilation, or do only small volume paracentesis, less than 5 liters, always accompanied by albumin. If you're worried that this is because of a decrease in effective arterial blood volume, discontinue diuretics, discontinue lactulose, because lactulose is, I don't know about Canada, but in the US, I was recently went to the ICU, and the patient was having a rectal tube in, and the note says, adjust lactulose at a rate of 20 to 30 cc's per hour. And I'm saying, who set these goals? There's no such thing as you adjust lactulose per cc. You adjust it by 2 to 3, 4 bowel movements a day. Of course, if you think this is a decrease in arterial blood volume, you give intravenous albumin or intravenous fluids, and you investigate or treat variceal hemorrhage. If always in a patient admitted with AKI, you have to make sure that this is not due to a vasodilatation, and it's due to an intrinsic kidney injury. So always ask whether the patient has been taking NSAIDs, because this is oftentimes the cause of kidney injury in these patients, or other nephrotoxins. Have they received recently IV contrast? And always I investigate ATN. I don't know if you have the biomarkers for ATN in Canada, but this is something that one would have to do. Now, what about encephalopathy? Encephalopathy does not kill, but can, in general, but it can indicate the presence of a complication of cirrhosis, and but can also indicate liver insufficiency. So the main goal of management of hepatic encephalopathy is to search for possible precipitant. So in general, they don't die. There's very few patients that die from brain edema, and these are usually patients that have been massively transfused. And then they get really hyperammonemia. But most cases are episodic, precipitant-induced. You have to rule out infection, GI hemorrhage, whether they have perirenal azotemia due to overdiuresis, if they have hypokalemia, if they've been on sedatives, constipation. Just yesterday, we had a patient that came in because he had some shoulder pain. The doctor gave him some opioid, stopped getting stools, and it came in with encephalopathy and a large protein in there. Now, never, and this is something that really bothers me when the fellow comes, and the easy way out is to say, that the patient has encephalopathy because they stop taking the lactulose. Never do this. You have to rule out everything else, because sometimes when the patient starts being confused, they stop taking their medications, including the lactulose. So never ascribe HE to having discontinued lactulose before ruling out all the other causes of encephalopathy. Now, what is the management? If the patient cannot protect their airway, they need to go to the ICU. You have to rule out other causes of altered mental status. The mainstay of therapy, like I said, is to identify and treat the precipitant. And again, lactulose, 25 milliliters every 1 to 2 hours until at least 2 soft or loose bowel movements, and then adjust to 2 to 3 formed soft bowel movements a day. This is very important. There's no need for protein restriction. I mean, some people were left on protein restriction forever, or at least for the short term. There's no need for protein restriction. And because Dr. Tandon invited me to give this talk, I would be remiss not to talk about sarcopenia. And this contributes to significant morbidity and mortality. It's usually assessed by CT. You can see here how the muscle here is, the paraspinal muscle is much decreased compared to the non-sarcopenic patient with cirrhosis. And there's the meta-analysis that shows that patients with sarcopenia is associated with a waitlist mortality that is much higher compared to patients without sarcopenia. And in a TIP study, post-TIP sarcopenia. So actually some patients that get a TIPS, actually their muscle mass increases, but the patients in whom there is sarcopenia, you can see here that they have a much greater mortality than patients who actually improved their muscle mass or did not have sarcopenia 3 months after TIPS. Which brings me to the question of TIPS. When should you think of TIPS? So TIPS is usually second-line therapy for variceal hemorrhage. And what happens is that when you have this shunt that is now decompressing the whole portal system, it also decompresses these varices, these varices that have bled or are bleeding. And at the same time, it reduces or normalizes the portal pressure. However, by shunting blood away from the liver, it can lead to hepatic encephalopathy or liver insufficiency, which is why we don't use it as first-line therapy. We recommend it in patients who have had a recurrent hemorrhage or who are at a high risk for recurrence. So when you see a patient that has had, and sometimes we see patients in the clinic that were that are having they just recover from a second episode and nobody ever thought of TIPS. So always think of TIPS as the patient has bled more than once. How about TIPS for ascites? For ascites, the way TIPS works is that not only is it decompressing the big veins, but it's also decompressing all of the sinusoids through this shunt here. And at the same time, the blood that's sequestered in the splenic circulation, because it's high resistance in the liver, it will transfer blood from the splenic to the systemic circulation, and this increases the effective arterial blood volume that we've been talking about. However, in the same way, the problems with TIPS are that they will get portal systemic encephalopathy and or liver insufficiency. What the complications that we have seen with TIPS for ascites is that with rapid reduction of ascites, they can get an umbilical hernia, and this can incarcerate, and then the patient gets intestinal ischemia. So again, TIPS is second-line therapy. We recommend it when the patient with ascites is no longer responding to diuretics, and the complication that you have to keep in mind is that they may get an intestinal ischemia. So let me go to the top 10 things that you should know about decompensated cirrhosis, because Dr. Abrales already talked to you about compensated cirrhosis. Variceal hemorrhage, spontaneous bacterial peritonitis, and intestinal ischemia are potentially lethal complications of cirrhosis that require prompt attention and action. Ascites and encephalopathy, on the other hand, are indicators of advanced disease, but are not lethal per se. So you have time to think about what you're going to do. Variceal hemorrhage, patients with cirrhosis present with GI bleed, I showed you, should not be over-transfused and should receive short-term antibiotics. In SBP, you should do a diagnostic paracentesis with every non-elective admission and with the development of any complication. I tell the fellows that if that day we're rounding and the patient is looking at us funny, we tap the belly if they have ascites. So tap the belly at the minimum complication. If there's abdominal pain, look for SBP for sure. Look for portal vein thrombosis, because that could have extended into the SMV, and that's when it's important to look for Doppler for portal vein thrombosis. And if the patient just got a TIS for placement of ascites, look for an incarcerated hernia. I understand that many people don't examine the abdomen that carefully. It recently happened to us again. That patient came, with AKI, a lot of abdominal pain, and you went and examined the belly, and there it was, the hernia was incarcerated and was necrotic, had to go to surgery. Anyhow, an uncomplicated ascites treatment is not urgent. This is not like pulmonary edema. And in fact, if the patient gets admitted, you have to discontinue diuretics. Acute kidney injury, investigate infection or variceal hemorrhage, hold non-selective beta blockers or any vasodilator, and ask the patient about NSAIDs. For encephalopathy, always search for possible precipitants, infection and bleeding being the most actionable ones. Titrate laxative to 2 to 3 soft bowel movements a day. Titrating in CC means that they're getting way too much lactulose. Nutrition in these patients is essential. I showed you how this can be associated with a higher mortality, and that protein should not be restricted no matter how severe or recurrent the encephalopathy. Tips, when are you going to think of tips? If a patient has bled from varices more than once, is requiring paracentesis too often, or if portal vein thrombosis is not responding to anticoagulation. Thank you for your attention, and I can take questions now.
Awesome, Lupe. As usual, that was fantastic. Thank you.
I hope so. It was not my regular talk, so it led to some thought.
Excellent. No, it was a nice whirlwind of everything. So we do have some questions. So Susan is asking about acute variceal hemorrhage. You mentioned that the giving blood obviously raises the HVPG. She's asking whether it raises up with crystalloid infusion also.
I don't know the actual answer to that. I would not expect it to rise as much, but if someone is bleeding, you're not going to, replenish. Oh, you may want to do crystalloid to increase their pressure, right? It's not going to be as effective, but I would not expect the portal pressure to increase that much with just crystalloid.
Okay. And then our next question is from Dr. Maddox. So can a patient with hepatic encephalopathy, can you talk about ammonia, measuring ammonia in these patients?
Yeah, that was, I forgot about that one. No, yes, that was one of the points that I had in my draft, and somehow it got lost in translation, but do not follow ammonia levels, all right? That would be the bottom line. So the time when I think ammonia levels are useful is when a patient comes in a coma in the ED, and you don't know what's happening. And they may look cirrhotic or not. They may look like they have cirrhosis or not. But you would draw an ammonia level, and if it's high, it's likely hepatic encephalopathy. But I have seen people with encephalopathy that may have a totally normal ammonia. A high ammonia may indicate hepatic encephalopathy. Now, once you start treating them, there is no sense in following ammonia level. So even though at the beginning you may want one first ammonia level, following them after treatment is useless, because the ammonia level may not go to normal and the patient is totally alert. For example, this patient that we just admitted, we never ever measured the ammonia level because we knew what was happening. It was a patient with known cirrhosis. We knew that he was on maintenance lactulose, got constipated. We gave him lactulose. We pan cultured the patient. Everything was fine. Never measured an ammonia level.
Okay. Okay, switching topics is with TIPS. Is there a role of beta blockers after TIPS?
That's a fascinating question, and that's a favorite of Dr. Alvarez, who I know is in the audience. So, if when they did the TIPS, the portal pressure went down to the goal, so if it was less than 12, you will not need a beta blocker. But on the other side, there's sometimes when the tips is very difficult, or you're concerned about the patient having encephalopathy or not wanting to reduce it to that much, you may leave the portal systemic gradient may end up being, more than 12. In those cases, you may want to add a beta blocker if you know that you were not at goal in terms of reducing portal pressure. But if it was at goal, there's no need to use beta blocker.
Okay, that makes sense. When we're using diuretics for ascites, I guess if perhaps a family physician is starting in the office, what diuretics would they use and how do they know how to titrate them?
Sure. So because the driving forces, and I didn't know how much time I had. So the driving forces for sodium retention are aldosterone, essentially. So you need to use an aldosterone blocker. So it has to be spironolactone. So that's number one. And you can use it with or without furosemide. So, but an element has to be spironolactone. So if the ascites is not tense, it's just very small, I would start with spironolactone alone. All right. If the patient gets hyperkalemic, then you can add a little bit of Lasix. And then you start increasing at a rate of, you could do 50-20 or 140 or 280. That's sort of the proportion that we keep in terms of treating these patients. But spironolactone has to be in the mix.
Yeah. So the 100 of spironolactone and 40 of Lasix. That
Yeah.
rate.
Mm-hmm.
Okay. You mentioned that you would discontinue diuretics in uncomplicated ascites during admission.
Correct.
Can you talk maybe a little bit about why?
Because it's work, because you're not, because diuretics are a symptomatic treatment. It's like you have to figure out what's going on with the patient. The patient came in for something. It's probably an infection or varicose hemorrhage or something not good, right? So why give them something that is just a symptomatic therapy that the patient is not needing, that may be a confounder in your assessment of the patient? I just tell them to stop them all the time. Then if everything is fine and we've ruled out infection or we rule out any bad things going on, then we can restart the diuretics. But I think that inpatient using diuretics is not, if they're uncomfortable, you do an LVP. But I think that diuretics, this I feel actually very strongly that diuretics are just symptomatic, could be a confounder in a sick patient. They could lead to AKI and favor AKI, so I would stop them.
Okay, so you restart them some point during the admission.
Oh yeah, during the admission once they're discharged, just leave them on their usual dose of diuretics.
Okay. Okay, so sticking with the role of ascites from Dr. Van Zanten, is there a role for outpatient treatment with albumin in large volume?
Yeah, I know. I just gave a lecture at UCLA and I showed the data. So actually I could share my screen. Can I share my screen is the question. Oh, the question, I don't know where that lecture ended up being. Oh, maybe not. So there's two trials of outpatient albumin. Let me show, I wish I could share my, hold on, let me share it. This is this one. So this one I don't want, I want the UCLA one. Okay. So let me show you.
And this is a hot topic right now for sure.
This is a hot topic, but this was I'm not among, this was a nuance thing, okay? So let me show you, this is it, okay? So there are two trials looking at chronic albumin administration in outpatient with cirrhosis and ascites. This is an answer trial. So this is in the Lancet. And you can see that weekly albumin infusions was associated with a better survival, with a better probability of survival than standard therapy. Okay, and not only that, it had lower rates of need for LVP, hyponatremia, SVP, hepatorenal syndrome. Amazing. Problem is that they did not use a placebo. All right, and that's why it's in the Lancet and not in the New England Journal of Medicine. Because if the patient is being seen weekly, you can imagine, as opposed to these patients that got seen like every 2 to 3 months, the doctor's going to be much more aware of any complication going on, and they may be more likely to diagnose an infection or anything that could be treatable. And that's why this paper, is not incredibly strong and needs to be replicated. On the other hand, from the Ginez group, they did a much better, methodologically better trial where they used biweekly albumin and midodrine, which would make sense. You're using a replenishing the volume and giving a vasoconstrictor, and a double placebo. And in this trial, there were no differences at all in the two groups. And they also found no difference in need for LVP, AKI, hyponatremia, bacterial infections, encephalopathy, or GI bleeding. Now, granted, these patients were sicker, so only God knows, maybe albumin just works in patients that are lower MELD, but I don't think we're there yet where we can recommend this. And plus, we find it very practical for patients to come in every week to get albumin infusions. I don't know how these people actually did it. What I want to also remark, and this I did not give, is this study that was presented at EASL that looked at albumin infusions in hospitalized patients. So they gave them albumin almost every day or every other day to maintain the serum albumin more or equal to 3.5 milligrams. They used 10 times more albumin in the albumin group than the standard therapy group. The primary outcome, which was a composite of new infection, renal dysfunction, death, was not significantly different between the groups. Not only that, but the serious adverse events, mostly respiratory failure, were more prevalent in the albumin group, and the cost was astronomical in the albumin group. So yeah, right around now, I'm not entirely a fan of albumin, but that it is what it is.
Okay, and that's a common question that comes up on the ward, actually. When do we stop giving albumin? Do we use a serum?
I mean, well, we have here, there's no restriction at Yale in albumin. We have patients that are going around with an albumin of 4.5, and you say, what's happening? At the VA, where we're more cost conscious, we are not using it anymore, but I think it's deleterious. I think, that study clearly shows, a higher rate of respiratory failure. It's pulmonary edema. We're using too much albumin.
Okay, so 35 is sort of where we would cut it?
No, not even. No. What I would say, I would not even cut it. I would just use it whenever you have to use it, like for infection, but not every day. You use it for whatever the guidelines say. If you do an LVP, you give it that moment. If the patient had an SBP, you give that moment. If they have AKI, once they've resolved. So just follow the guidelines that we have so far, not to use it every day. Not to any level of albumin.
Okay, excellent. Okay, next question is around, in patients with cirrhosis, this is from Dr. Pai, in patients with cirrhosis on cross-sectional imaging and ascites, they don't have splenomegaly. Is that theoretically possible? To have cirrhosis on cross-sectional imaging and ascites, but not to have splenomegaly? Is it cirrhosis, or is it something else that's causing it other than portal hypertension?
Well, I have seen cases where the spleen is not incredibly big. It's not. I mean, it's odd, but if the patient has ascites, it has a nodular liver and collateral something, the patient has cirrhosis. I don't care what the size of the spleen is. Would be my thought.
So looking at multiple features.
Yeah, totally.
So this happens a lot. This is a good question from Dr. Churchill. Is there any utility in a diagnostic paracentesis if the emerge resident is already given antibiotics overnight?
Oh yeah, that I want to kill myself, seriously. Yeah, it all depends on when they got the dose of antibiotics, right? So usually the PMN start coming down, like in 20, Runyon had a study actually where he shows the decrease in PMN count. And you see it like going quickly in 24 hours. So if it's less than 24 hours, there may still be some utility in doing the tap.
Okay. And then Liz follows up on that. How do you manage patients that have high polymorphonuclear cell counts all the time, despite treatment, and that they're clinically well with no symptoms?
Yeah, when I have seen that more recently in heart failure. So I have this theory that patients with heart failure are the ones that have this high PMN count, even though I have not found even in Runyo's very old studies, because they keep having high PMNs and nothing is cultured. They keep having a high PMNs, and you give them a course and they still high. I think that one should stop treating them at this point. I have not seen it that much in patients with cirrhosis per se. We do, I do remember a couple of patients that are in the ICU, and it may just, I don't know what to do about that, but once you've given the whole course, if the patient is clinically stable, I would ignore it. I mean, you always have to guide yourself by what the patient looks like at the end of the day. You know, if the patient looks totally fine, is afebrile, no leukocytosis, entirely asymptomatic, and keeps having a high PMN count, you know, and again, this is not something that I've seen very frequently, then you can just stop doing it, because we stopped doing it in a couple of heart failure patients that had this.
Okay. Okay, let's go back to tips, Lupe. So do you have an age cutoff for tips?
Well, most of the guidelines say 70 years, 77, because you're more likely to have heart failure, and with that volume that gets to the central circulation, you may precipitate then heart failure.
Do you do any workup prior to that to look for?
Yeah, in every tips patient we get at the very least a cardiac echo, and Dr. Abrales and I participate in the ALTA consensus conference for tips. And actually, we're we're going to be writing the guidance for the ASLD on tips, and we're going to make sure that we put this in, you know, about what are our cutoffs and so forth. But in someone, they have to have at least a baseline cardiac echo to make sure that they don't have a pulmonary hypertension or heart failure.
Okay, and when you're doing a tips, Susan is asking, should beta blockers be discontinued prior to the tips so that the HVPG measurement you get is more accurate?
I have never done that. They are what they are, you know. No, I don't think I've actually done that part. They just go get the tips, and I don't think that the effect of the beta blockers will be, because you're actually going in and measuring the portal pressure per se. I don't think that the beta blocker in itself. I would like to hear what Dr. Abrales has to say about this, but I have never even thought about discontinuing the beta blockers before doing a tips. Just because it's usually, if it's a bleeding thing, who cares, right? If they were on beta blockers or not. If it's for ascites, I don't know if it would alter the measurement that much. I have not thought about it.
Okay, we'll see if Juan types. I don't know. He's
Yeah.
on call tonight for COVID, so.
Oh, he is.
So he might not be here. Yeah. Does tips cause systemic hypotension?
It could, if you're getting a lot of blood going in, that is somehow going to increase nitric oxide. If the shear stress increases, you get more nitric oxide. It may be that you get hypotensive, but not in general.
Okay. And Winnie's asking whether or not you have any suggestions for refractory hyponatremia that's not responding to the usual stopping diuretics and fluid restriction.
This is a very difficult question. This is a patient who's on the transplant list.
Sure. Yeah, where we need to get that sodium up.
Yeah, so in those patients, we did use this setup. If the patient's on top of the transplant list and they don't want to have him go hyponatremic into transplant, then that is perhaps the only scenario where I would give cetabaptan, one of the Vaptans. And Juan agreed with me. Would not discontinue beta blockers before tips. Normally, we do not give much thought to the initial therapy once we're there. Yeah, I mean, yes, there's zonked. So yeah, there's million issues by which they may get a lower than normal pressure. So we don't pay attention to that.
Okay. And then this is an interesting question from Mayur around beta blocker use in compensated cirrhotics who have, based on the PREDESI data.
Oh yeah, I can share my screen again. We have, this is a new paradigm that is just off of the PREDESI study. I should give you my other lecture. Anyhow. So this is sort of like a, where is it? Here. So this is sort of a new paradigm, right? It's off, again, this is not a recommendation. This is based on the Predesi study and all the Anticipate studies, right? So once you make a diagnosis of compensated cirrhosis, right? You look at the liver stiffness measurement and the platelet count. These are from the Anticipate studies, the regular Anticipate and the national Anticipate. These are the cutoffs. If you have liver stiffness more than 25, you have CSPH, except in obese patients where they underestimate the HVPG. Liver stiffness measurement, and in the NASH Anticipate, they have a nomogram that you can calculate actually whether they are likely or not to have CSPH. Liver stiffness measurement more than 20 to 25 and a platelet less than 150 makes the diagnosis of clinically significant portal hypertension. So this is now, the paradigm shift is that we don't care if they have varices or not. We just care that they have clinically significant portal hypertension. And if so, one then starts carvedilol, and I would prefer carvedilol because it was much more effective, or propanol to prevent decompensation. If they don't meet this criteria, one would monitor this yearly to see when they reach the criteria to start the beta blocker. If, on the other hand, they refer the patient to you because the patient already has varices on endoscopy or abdominal collaterals on imaging, which means that by definition that they have clinically significant portal hypertension, then you can do physical examination, lab test, just to determine whether the patient has cirrhosis or not. If the patient has cirrhosis, because we already know that the patient has clinically significant portal hypertension, we go directly to start carvedilol or propanol without doing any, well, the patient already has had an endoscopy. If we think that this is pre-hepatic or pre-sinusoidal, so the patient does not have cirrhosis, then we go back to doing an endoscopy to see if they have moderate to large varices, and then starting propanol or carvedilol. But the goals are entirely different. In this, these goals are just to prevent variceal hemorrhage, whereas in this scenario, where we're targeting clinically significant portal hypertension, we want to prevent decompensation. And that's key. And this is because of the Predesi study, which is right there. So these were all patients with no or small varices who had CSPH, and the outcome was any decompensating event. It was significantly lower in the beta blocker group. And actually, when of the 3 decompensation, so any decompensation meant ascites, variceal hemorrhage, or encephalopathy. And of the 3 events, ascites was the only one that was significantly different. And that's because it's more frequent, but if you think this is the first trial that actually shows this. But growth of varices was also reduced by 50%. So one would assume that you're also, perhaps preventing variceal hemorrhage in the future. So that is the new paradigm. We're hoping that this will be brought up at Baveno later on in the year. But for now, this is actually during the pandemic, what we were doing is like looking at the platelet count, and actually Juan has a graph where she shows that if it was like less than 150, I think, we did 130, you were likely to have CSPH. So, when we could do fiber scans or endoscopies, we would start the beta blockers just on the basis of having a low platelet count. But now that we have fiber scan, we do both.
Okay. Lupe, I'm going to keep you for 2 more quick questions, and then we'll dismiss. So one question is around, you talked about renal failure. Should octreotide and midodrine be started right away, or should we do other things before we start that?
Well, you guys have terlipressin, right? Oh, you don't?
No.
Oh, I thought you had terlipressin. Oh, so we're in the same boat, which is a bad boat to be in. But anyhow, so yes, we start octreotide and midodrine because essentially you can do it on the floor, and there's a minimum. I recently saw a patient that actually responded. So there is a minority of patients that will respond. So what we try to do in our Yale algorithm that no one followed, was that we started off treating midodrine and we would accelerate the dose very rapidly so that in 2-3 days we would know whether there was, and we followed the map, not only the credit, but we followed the map. If there's no response in map, you know that it's not doing anything. So if there was no map and no response in terms of the creatinine, then we had an arrangement with the ICU guys to give IV norepinephrine. So they accepted. So we had a meeting with the nephrologist, with the whole thing. We had an algorithm was pasted all over the place, how they would go into the ICU and they would get norepinephrine, and it worked. And so, I mean, it works. So they start getting the urine out. And in fact, a patient of mine said, I am not going to have a Foley. And so he didn't have a Foley, but the creatinine came down. It was fine, it works. The problem is that there's million attendings in the ICU, and they see this patient that has AKI, and many of them were made comfort measures only when they were there for norepinephrine infusion. So that was a problem. So we wanted to write a paper on the results, and the only thing that we could write is that no one follows any algorithm.
Okay, but we would start with albumin or fluid, resuscitation.
You start with albumin, treat and midodrine. That doesn't respond, go for norepinephrine.
Yeah. Okay, let's do this question on the COVID vaccine for cirrhosis. What are your recommendations for that? Do you have thoughts on that?
They should get it for sure. We are doing well for now. Our priorities have been the post-transplant patients and the patients that are active on the transplant list. Because we definitely, those are like number one. And then I would start with the decompensated cirrhosis. Yeah.
Okay, and then last, one more. Preemptive tips for acute on chronic liver failure. Any thoughts on?
No. Okay, so that paper is misunderstood, all right? I think it's a Trebisca paper. That is not preemptive tips. What they did is rescue tips. So these were patients that were, so that's a journal of hepatology. If you're referring to the journal of hepatology paper, they call it, well, maybe they had acute chronic. They were very sick cirrhotic patients that bled when they were doing the ligation, they kept bleeding. So this was not preemptive, this was rescue tips. And they show that even these very, very sick patients doing tips as a rescue was associated with a benefit in survival. But it was not preemptive. The preemptive tips, the indications for preemptive tips are child C 10 to 13 points. So 14 and 15 points are excluded. And theoretically child B that are like 8 and 9 points that are actively bleeding at the time of endoscopy. But again, this needs to be reevaluated because all these have come, if you look at the number of patients that have received preemptive tips in the setting of a randomized controlled trial, it's less than 150, if you think about it. Yeah. So we're making huge recommendations based on really not a lot of patients. So this needs to be sort of like, I mean, I do believe that one has to do it, but definitely in acute on chronic liver failure. I mean, if they're bleeding out, you're going to do it. You're going to put tips in, and that's what that paper shows.
Okay, excellent. So thank you, Lupe. That was brilliant as usual, and thank you for.
I hope it was good. It was out of my comfort zone, I have to say, but I hope that tips were there, and I wanted to make them like easy ones, but I forgot some, but anyhow, I just wanted things that drive me crazy. I said, okay, what drives me crazy? Those are the ones that I'm going to put there, right?
No, it was fantastic. And next week, we're going to be having another incredible session on alcohol use disorder and cirrhosis management by Jessica Mellinger out of Michigan. So that also is going to be an excellent talk, I'm sure. So thank you, Lupe. Thank you, the Physician Learning Program, and everybody.
Thank you all for being here, and thank you, Punita, for inviting me.
Yes, no problem. Thank you.